My main affiliation is with the School of Public Health, where I'm on the faculty of Health Management and Policy, and I teach health economics in our master's and doctoral programs. In addition, I'm involved in several centers, both of which are part of IHPI, the University of Michigan's Kidney Epidemiology and Cost Center, and also with the Value-Based Insurance Design Center. The areas that I'm involved in include end-stage renal disease, long-term care and aging, and value-based insurance design and healthcare costs. My work in end-stage renal disease has focused on redesign of the payment policy for kidney care. CMS wanted to change the incentive structure, and then we developed the research base for the new payment system. In addition to that, I'm involved in a project on kidney care quality measures. We had overuse of services under the prior payment system that rewarded facilities for being very aggressive in their dosing of various expensive drugs delivered to dialysis patients. And then in terms of value-based insurance design and healthcare costs, kind of like the kidney work, it's a lot of payment system redesign. I think a good example of how the work I'm doing has the potential to have impact on a variety of different stakeholders is the work on the dialysis payment system. There are significant savings, potentially on the order of a couple $100 million a year, but then there's also the benefit to the patients themselves. There was some pretty solid evidence that patients were actually being harmed by overdosing of some of these medications. The biggest global challenge that my work addresses is trying to find the right mix of instruments to improve the overall functioning of the healthcare system. We can either try to reform the existing fee-for-service based incentive structure, you get paid for volume, while other health reforms really try to fundamentally move away from that payment structure. To some extent, those two different approaches are complementary, but to another extent, they might be contradictory. And figuring out whether they can coexist is really, I think, the major challenge going forward in the next 5 to 10 years. IHPI can kind of extend its reach far beyond the building here, even though what's here in the building itself is a pretty broad and impressive set of individuals and groups. The formation of IHPI has really helped my own research work and collaborations in a number of tangible ways. The first is through the U.S. Renal Data System contract that we just won, where we both had new connections in terms of collaborators and access to certain data sets that we would then not have to build into our own budgets entirely to purchase. In addition, there have been entirely new projects that are under development. I'm working with Eve Kerr and several others on a project focused on overuse of care. It's just kind of getting off the ground and wouldn't exist without this institute. Health policy is going to have to focus on sustainability. That's a word we hear a lot in the environmental realm. It's also really a word we should hear a lot in the healthcare and health policy realm. Everybody likes quoting statistics about the percent of GDP we spend on healthcare, and that's now more than 1/6 of all the sort of economic activity in this country. We also have to look at the value we're getting for what we're spending, and then making sure that the entire system is on a sustainable long-term trajectory.